So primary hemostasis disorder is mainly related to platelets, because platelet is a key element in primary hemostasis. Okay. In the blood, there are three main kinds of cells: white cells, red cells, and platelets. White cells are related to the immune system. Red cells are dedicated to the transport of oxygen. And then our platelets are the ones which are dedicated and linked to the primary hemostasis. So when we speak about primary hemostasis, we speak about platelets and platelet disorder. Okay. So our platelets has different way to be activated. Okay. At the normal level, they are just resting, oval shape, going well. When there is a vascular injury, they immediately adhere to the endothelial which is exposed from the injury of the vessel. Then this adhesion will release platelet contents. They will activate themselves, and they will also call for colleagues. They will call for support with other platelets to activate the other platelets. So they are themselves all activated, okay, to come and to stick to the injured part where there is the vascular injury. And then this call for other platelets, make an amplification loop. Then you get a lot of platelets activated at the same place. You get a plug of the different platelets which are just binded all together, making this platelet plug formation. Okay? And they are linked thanks to the fibrinogen, which is making bridges between the different platelets. So these are the three main parts of the workloads of the platelets. If we take them one by one, step one is the adhesion. So we have a vessel injury. The endothelium, which is not supposed to be seen normally, is then presented to the platelets. And so the platelet will go to bind to the endothelial, to the endothelium, to the collagen, thanks to different receptors. So that can be directly with the receptor GP1A2A or GP6, or it can be also indirectly through the VWF, so the von Willebrand, okay? And then the platelet will bind to the von Willebrand, to the collagen indirectly, thanks to the von Willebrand, with the receptor GP2B59. Okay? And I would say it's not important to remember the name of the different receptors. It's just important to remember that there are different receptors, because depending on the disorder of the receptor itself, it will be a different platelet function disorder. Okay? So this is our first step. Platelets are making adhesion, and then they are going to the activation. When they are activated, the platelets change the shape. They become what is called pseudopods. They will activate a new receptor, which is then expressed, the GP3A receptor, okay, which is then activated. They will release some internal contents from the granule contents, and they will express new receptor with a flip-flop of phospholipid of the membrane, which are then going outside. This release of new receptor, the activation of the GP2B3A will then support the aggregation for the next step. Okay, step 3 aggregation. The platelets aggregates all together and they stick together to perform the platelet plug. When the platelet plug is formed, we have performed primary hemostasis, and then we'll go to the regular hemostasis. But since we are speaking only about primary hemostasis, we'll focus on this activation of the platelet and with the different receptors which are involved from the platelet to make this primary hemostasis. Okay. This is done in a very short time, actually. From the vessel injury to the platelet plug formation is made within 3 to 5 minutes at maximum. Okay? So that's a very reactive system, which is made in a very short timing. Okay? And this is represented in this video, where you can see at the beginning the vessel injury, platelets coming, adhering, activating, asking for support, amplification, and then making the platelet plug. Okay. So our platelets making the primary hemostasis are using different receptors, and actually these different receptors may be involved in this, well, they have not, maybe they are involved in the different function of the platelets, but then we can recognize them by activating selectively one of them by using agonists. Agonists are substances which are combining with a receptor, okay, to initiate an activity. So when we want to measure or when we want to know which receptor is having a default, we will use one agonist or another one, or a combination of agonists, and the reaction of our platelet linked with these different agonists will let us know which disorder are present in our sample. Okay. So you can see the different receptors, the different agonists we can use to identify the different receptors. In terms of platelet function disorders, they will be definitely linked to these different receptors, and platelet function disorder can be either inherited or acquired. Inherited disorders are relatively rare, and they are usually mild. What I mean by mild is that they are not severe, so they are not recognized early in life. Usually, people having inherited disorder for platelet function can have a normal life for a very long time, and they are just diagnosed as having this inherited disorder at maybe 30 or 50 years old. Okay, it's not something which is recognized or diagnosed early in life. These inherited disorders are linked to the different receptors, and depending on the receptor, then you can get what is called Glanzmann thrombasthenia, or Bernard-Soulier syndrome is just the name of the disease linked to a specific receptor. Okay. This can be also a disease due to the activation of the platelet during the release of dense granules or alpha granules, or the link to the von Willebrand, okay, the VWD. So platelet function disorder can be inherited. This is relatively rare, or they can be acquired. Okay, so that can happen during the life. But actually, what is the most common acquired disorder, if I can say, is actually treatment. Okay? When patients are given a treatment, an antiplatelet treatment, antiplatelet drug, following angioplasty, following a therapy. Okay? So acquired disorder can be acquired VWD, acquired von Willebrand disease, renal insufficiency, liver disease, either you don't produce enough or you don't eliminate it well. Autoimmune disorder, like antiplatelet antibodies, but definitely the most common is antiplatelet drugs. So, why antiplatelet drugs are prescribed? Because they are used after what is called major adverse cardiovascular events. So basically, when you have a patient who made major cardiovascular events, that can be acute coronary syndrome, percutaneous coronary intervention. Okay, so basically something strong and severe. So you make a therapy, make angioplasty. So you make this angioplasty. So basically, you put a stent into the coronary. And then you give a treatment to get the patient going well. The treatment is usually called tienoperidine, so antiplatelet drugs, and aspirin, which is also an antiplatelet drug. But the main issue is that in 5 to 15% of the case, the patients will still have a recurrent thrombotic event, okay? So meaning that you need to make a new surgery, you need to treat it again, the problem from the beginning. So to avoid that kind, or to minimize as much as possible that kind of adverse events, you should evaluate the response to the treatment of your patient. And this is done with platelet function testing, okay? So our platelet function testing, how will we be able to make it? How to monitor platelet function? And why? So the main reason of the why is to get the value of our treatments, okay? To monitor antiplatelet drugs in terms of variability of the response of the different patients, and to diagnose the different inherited disorder that can happen in different patients. Okay. So this is why. Then how to monitor, how to measure? Our proposal is based on light transmission aggregometry, so it is a thromboaggregometer based on light transmission aggregometry. And why do we base our system, our solution on light transmission aggregometry? Basically, for a very simple reason, it is the gold standard. We like gold standards. We have it for a mechanical detection system on our instrument, on our hemostasis instrument. We want to stick with gold standard detection methods. For thromboaggregometry, the gold standard is recognized to be light transmission aggregometry. So this is a system we use. What is the principle of light transmission aggregometry? It is actually much more easy than what you can think. The principle is that you take a PPP, platelet per plasma. Platelet per plasma is quite limpid, okay? So the optical signal, the transmitted measurement is very good, okay? So this platelet per plasma will give us the value of 100% of transmitted light. Okay. So that's our 100%. Then we will use a PRP from our patient. So PRP for platelet-rich plasma. And platelet-rich plasma is actually having a lot of platelets, so it is quite turbid. So the transmitted light is not good. So this will give us the baseline of 0% of transmitted light. Then we will add an agonist into our sample, in our sample. And this agonist will react with the platelets of the sample, of the patients. This aggregation will make a kind of aggregates, flocculates, so they will be combining. So the transmitted light will actually increase because the sample is less and less turbid, okay? And what we will measure with the thromboaggregometer is just this kinetic of reaction. Okay. So we can see the turbidity of our sample, which decrease, so the transmitted light increase, and this is what we measure with our instruments. And this value, or this level of increaseness, will be then proportional to the quantity or to the quality of the platelets in our sample. This is a principle. We measure it in the infrared wavelengths, so more than 700 nanometers. For a simple reason, it is to be far away from optical interferences, HIL interferences like hemolysis, icterius, or lipemia interferences, which will affect optical measurements. And this is an optical measurement because we make it in the infrared measurements. But we try to be as far as possible from these different interferences. And in this screen, you can see that actually it allows us to use quite a lot of samples, even when they start to be icteric, hemolyzed, or lipemic. You can see the acceptance range on the screen of the different samples that can be used, and actually that's quite usually enough to show that a majority of samples can be used for thromboaggregometry and for platelet function disorder. Here is just to show you an example of curve that you obtain with the Stagó T8 or thromboaggregometer instruments when you are performing thromboaggregometry testing. You use your platelet-rich plasma sample without agonists, giving you the baseline. You add the agonists, you start the measurements, you see the kinetic of the formation, the kinetic of the curves, giving the transmitted lines. Okay. Well, to perform these different tests, so you need an instrument with light transmission aggregometry, the TA, so you saw the curve, and you need a reagent. This reagent will link the different receptors of the platelets to be able to activate one or several of them, and the differences between the different kinetics will allow you to distinguish the different subtype of disorder of your platelets. You need several agonists to be able to selectively assess what kind of disease it is, or to assess also the platelet function testing in terms of antiplatelet therapy. That's why you have several reagents, agonists, like arachidonic acid, ADP, collagen, epinephrine, TRAP6, or ristocetin. Okay. So, when can you use a thromboaggregometer? You can use this thromboaggregometer, as we are saying from the beginning, to test platelet function disorder and to monitor antiplatelet drug monitoring. A third possibility to use a thromboaggregometer is for the VWD identification, so for the von Willebrand disease identification, because in the diagnosis tree of the von Willebrand disease, at a certain step, at the end actually of the step, you need to perform a ristocetin-induced platelet aggregation testing. And that kind of test needs a thromboaggregometer to be performed. There is a fourth possibility to use a thromboaggregometer, which is not within the scope of this presentation, because this presentation is about primary function testing, so a platelet function testing, primary disorders. And the first possibility to use a thromboaggregometer is when you need to confirm HIT for heparin-induced thrombocytopenia. So this is absolutely not related to platelet function testing, but this is something that can also be measured with a thromboaggregometer. So when you invest in a thromboaggregometer, you will have it definitely for the platelet function testing, but you can also use specifically and apart, I would say, for the heparin-induced thrombocytopenia confirmation. Let's start with the first one, which is the diagnosis of platelet function disorder. When you want to perform a platelet function diagnosis, you need to follow an algorithm tree. Okay, there is a diagnostic algorithm. And first, you perform clinical evaluation of the patients. Then you will make regular platelet counts and routine coagulation testing. If these platelet counts and routine coagulation testing are normal, it means that the issue is not on the hemostasis part. So you will go for the platelet function studies. platelet function studies, you take your thromboaggregometer, you take the different agonists that I show you, and then you will use them at different concentration. You will make a selection of several agonists, and actually the pattern of the curve, okay, the way you will get reaction curves that you will compare with normal samples and with also already given values which that we have in another book. You can compare the pattern of the curve that you get, the kinetic of your curve. You will compare it with normal and abnormal results, and then it will allow you to distinguish the different subtype of platelet function disorder. So I just put some example of the different curves that you can obtain with the different agonists, and you can see that you will get different reaction patterns depending on the disease. Okay? With, for example, a normal sample will get everything reacting, because this is the first time. So whatever the agonist you use, you get a normal reaction. For Glanzmann thrombasthenia, you can see that ADP, collagen, and AA, so arachidonic acids, are flat. There is no reaction. But it works with the ristocetin, which when it's a Bernard-Soulier syndrome, you can see that ADP and arachidonic acid are normal. You have something a little bit strange with the Bernard-Soulier syndrome, and the ristocetin is flat. Okay, you don't get any reaction. Okay, so and this is the comparison of the different values or the different kinetics that you get with your sample that you compare with a kind of book, and this will give you the different diagnosis. Okay, so that was our first reason to use the thromboaggregometer. The second possibility to use a thromboaggregometer is for the von Willebrand disease identification, okay, with the test ristocetin-induced platelet aggregation. And then you can see that we are using platelet aggregation, so that's why we need our thromboaggregometer. So we are back to the same diagnosis algorithm, but instead of being normal in terms of platelet count and routine coagulation testing, then we have something abnormal. And in this case, we will need to continue the algorithm decisional tree to the von Willebrand disease. So von Willebrand disease is actually called von Willebrand because it was discovered by a Finnish doctor, Erik von Willebrand, in 1926. It's linked to the von Willebrand. It can be either the concentration, the quantity, or the quality of the von Willebrand. It is quite common congenital disorder, the most congenital disorder in hemostasis, but actually the majority of them are mild disorder, so they are not clinically relevant. Just a few of them are really clinically relevant. And in terms of symptoms, it really looks like hemorrhagia. Depending on the subtype of von Willebrand disease, then we'll call it type 1, type 2, or type 3. Type 1 is just you don't have enough. Type 3, you don't have at all. And type 2 is you have, but it doesn't work well. And depending on which part of the von Willebrand doesn't work well, you will have subtype. To diagnose the von Willebrand disease, you have first to make first-line intention of test, which are activity tests, RCO, ristocetin cofactor, okay, and antigen, Ag. Activity, RCO, will give you if it works well. Antigen will give you the quantity. So if you don't have at all, then you can go directly for type 3. If you have, but not enough, then you will go for type 1. And if you have a normal quantity, but with not a good activity, it will go for the type 2. And then to diagnose precisely what kind of von Willebrand subtype it is, you need additional testing. This additional testing will be performed with factor 8 binding, so the link of the von Willebrand to the factor 8. And when you have an issue, it is called type 2N. Or when you continue with collagen binding or ristocetin-induced platelet aggregation. Okay? And that's in this specific case, to be able to distinguish type 2A from type 2B, that you need the ristocetin-induced platelet aggregation that is performed on the thromboaggregometer. So this is the second reason to use a thromboaggregometer. That's just a short sum up to present you the different reagents that can be used with Stagó to perform a von Willebrand disease. Okay. For the activity, you have the STA VWF RCO for von Willebrand ristocetin cofactor. For the activity, you will be able to use VWF antigen, so you will be linked to VWF antigen with either the automated one, STA LIA test von Willebrand antigen, or the manual method with the acerachrome. This is the first screening step. And then when you need to go further into the details to distinguish which subtype is involved into your von Willebrand disease, you can use acerachrome von Willebrand collagen binding, acerachrome von Willebrand factor 8 binding, and then the thromboaggregometer with the ristocetin as an agonist to check the ristocetin-induced platelet aggregation. Okay. The third main reason to use a thromboaggregometer is to follow up the antiplatelet drugs monitoring. And actually, this is the most common. So that's what we said previously. 5 to 15% of the patients with angioplasty don't react enough or properly as expected, let's say, to the treatment. So they are making a recurrent thrombotic event. To try to decrease this percentage, you need to adapt the platelet drug therapy. And to be able to adapt, you need to monitor it. So to monitor, to follow up the antiplatelet therapy, then you need this thromboaggregometer with the different agonists. Okay? There are actually several antiplatelet agents. The most common used and the first one used is aspirin. Then there are usually P2Y12 inhibitors, which are either thienopyridine or non-thienopyridine. But I would say it's not so important. What is important is to know which therapy or which drug is given to the patient, so you can select the correct agonist to perform the monitoring. And then the different agonists, depending on the treatment, will provide you different patterns. Okay? So this one is a pattern that you obtain with a patient under aspirin. This one is a pattern that you obtain with a patient under P2Y12 inhibitors. And then you perform your monitoring, you perform your curves, and you compare them with a book giving this kind of curves, and you are able to monitor and to see if your patient is responsive to the drug, if you need to increase the dose, or if you need to change the drug to something that the patient is more reacting. Okay. And then the fourth possibility to use a thromboaggregometer is to confirm heparin-induced thrombocytopenia. But as I said, since this one is not related at all to primary hemostasis disorder, this is just for you to know that there is an additional possibility for the use of a thromboaggregometer. So, as conclusion, I hope you feel a little bit more confident with platelet function testing, with primary disorder testing. Okay. This is usually considered as something difficult, a little bit exotic maybe, but actually it is not. It is not difficult. We can provide a lot of resources to support you on this. And the first resources available are actually a booklet explaining platelet function testing, a practical manual for the follow-up of the platelets, and then on our website, we have actually 2 webinars speaking about platelet function disorder, platelet function testing, and also a podcast. Marujan explains that you can find a lot of resources, so you can find some of them about platelet function testing, so as webinars, but also as a podcast in our resources, in our website. Merci.
Ես ուզում եմ իմանալ սարքը բոլոր տիպի P2 Y12-ի ինգիբիտորների ինֆորմացիան է տալիս, թե ընդհանուր ռեցեպտորների ինգիբիտորներ նկատի։
So, no. The instruments just make the kinetics. Okay? It gives you the patterns, and then you I would say, have to compare the patterns that you obtain with regular patterns that you can find in these different books. Okay, and the comparison between what you get with your patient compared to a kind of book of patterns that you will be able to say it is this drug, this is reacting well, or this is not reacting well.
Չէ, ուղղակի մնացած ապարատները, որոնցով որ մենք չափում ենք լոբիտոգրելի ռեզիստենտականության տեստը, պահանջում է հագեցվածություն եւ մնացած ուրիշ ֆակտորներ եւս։ Բայց լոբիտոգրելից բացի եւ ասպիրինից բացի մենք ուրիշ հնարավորություն չունենք տիգագրելոլը կամ այն մնացած բոլոր P2 Y12-ի ինգիբիտորների մասին ինֆորմացիա դրա համար էի հարցնում։
This instrument will actually, depending on the agonist that you use, will be able to provide you several answers. Okay, and that's why you have actually all these agonists, all these reagents available to perform the different possibility and the different detection.